Hi viewers, welcome back. As we have already discussed about the causes of male and female infertility, now let us discuss about the management procedures which is available. We have two advanced procedures to improve the fertility rate in many infertile clients. One of the major procedure is intrauterine insemination. Now let us discuss about this IUI in detail. What is intrauterine insemination? It is the process of directed transfer of the processed sperm into the uterine cavity at the time of ovulation. The advantages of intrauterine insemination are: it is easy to perform, it is non-invasive, there is minimal complication as minor discomfort, antenatal and intranatal complications are very less and is very cost effective. The indications in males include ejaculatory failure, impotence, hypospadiasis, and infrequent physical contact during the fertile period. The indications in mild male subfertility include OAT syndrome, which is nothing but oligospermia, asthenozoospermia, and teratozoospermia. The indication in severe male subfertility is when the count is less than 5 million per ml, when the normal morphology is less than 2.5%, and if the motility rate is less than 10%. The indications of IUI in female patients include poor cervical mucus, endometriosis, and vaginismus. The indications in both males and females include immunological factors in which there is male anti-sperm antibodies and female anti-sperm antibodies are present. In cases of unexplained infertility, IUI is very effective. There are women with patent tube and IVF is not possible. Contraindications are cervical atresia, endometritis, cervicitis, bilateral tubal obstructions, amenorrhea, and severe oligospermia. The steps in IUI include selection and counseling, ovarian stimulation, monitoring the follicular growth and the endometrial development, the timing of insemination, sperm preparation, and insemination. During the selection process, we are going to do the basic investigations for infertility, which may include semen analysis, mid-luteal progesterone level assessment, hysterosalpingography, baseline USG, and ovarian reserve test. During the counseling process, confidence of the male partner is supposed to be achieved, cost effectiveness of the procedure to be explained, the complications and the success rate has to be explained to the clients, which is only 15 to 20% per cycle. The steps of the procedure should be explained in detail and the clarifications of the procedure must be done. It is also the responsibility of the counselor to promote positive approaches towards the procedure. Ovarian stimulation is done to increase the number of eggs, which is supposed to be more than 4 available, and thereby to improve the chances of implantation. It is also done to increase the steroid production, to increase the chances of fertilization, and thereby to improve the chances of conception. The disadvantages of ovarian stimulation is OHSS, which is nothing but ovarian hyperstimulation syndrome, multiple pregnancies, and the cost of the drugs and the hospital charges during the procedure. Third step is continuously monitoring the follicular growth and the endometrial development to assess the time for insemination. Time of insemination is done with ultrasonography and with urine LH surge. Viable spermatozoans should be available in the female genitalia at the time of ovulation, as the lifespan of sperm is 2 to 3 days, but for the egg it is only 12 to 24 hours after ovulation. Method to assess the LH surge is serum LH surge plus 12 hours, urine LH surge plus 24 hours. There may be follicular rupture and IUI after 36 hours of urinary surge is done. Next comes US folliculometry. Here, the HCG is administered when the leading follicle is 17 to 20 mm. HCG should be withheld if the number of the mature follicles are more than 4 and the number of follicles are more than 8 and the size is more than 12 mm. Optimal time interval from HCG administration to IUI is 24 hours to 48 hours. The choice should be based on hospital facilities, convenience of the patient, and the cost and the dropout levels. Normally, two inseminations are done. One insemination is performed 34 to 38 hours after HCG administration, that is 24 to 36 hours of urine LH surge, or the next day after HCG. And the second insemination is performed 24 to 48 hours after HCG and 12 to 34 hours after HCG. Sperm preparation is done by two methods, that is swim up method and density gradient centrifugation. The sperm is collected by masturbation after 2 to 3 days of sexual abstinence. Avoidance of lubricants to be done, that is to prevent the contact between the lubricant and the glands. The container should be warm enough to avoid cold shock. Addition of culture media to the container before the collection is required. The selection of the method. In case of normozoospermia, swim up method is used. In case if there is a sperm disorders like OAT, DCG technique superior to the swim up method is preferred. In case of high leukocyte concentration, swim up for semen collection is done, and DCG technique, that is sperm wash only after the cell separation, is done. During the final insemination, the woman should be in full bladder to facilitate the straightening of the uterus. You have to provide a lithotomy position for the women. The cervix is exposed with a bivalve speculum and then rinsed with the saline. The catheter is firmly connected to the cone of 1 cc tuberculin syringe. Plunger is withdrawn and the sperm suspension is aspirated without any air bubbles. The sperm is suspended in a small amount of media which is less than 0.5 ml, and we are supposed to prevent the expulsion or the reflex during the uterine contractions, that is after the procedure. Then the catheter is inserted approximately 6 to 6.5 centimeter. Be careful not to touch the endometrium, as damage to the endometrium can affect the implantation process. Inject the sperm. Leave the catheter in place for a short time and remove it slowly. The patient rests in supine or reverse Trendelenburg position for more than 10 minutes. Post procedure, the woman resumes her normal routines after insemination. Explain that the loosened cervical mucosa doesn't indicate that the sperm has flowed out. Abdominal cramping can be relieved by use of acetaminophen. Light bleeding or spotting can be normal. An urinary or a serum pregnancy test is done usually after 2 weeks of IUI. If the woman has received HCG for ovulatory induction, she may remain positive for the next 12 days. Number of IUI cycles depend with individuals. 3 to 6 cycles according to the type of infertility can be done. 85% of IUI pregnancies occur in the first 4 cycles, whereas 71% of IUI pregnancies occur in the first 2 cycles. The complications include uterine contractions, intrauterine infection, that is PID in 0.01 to 0.02 cases. Rare upper genital tract infections can be seen. Psychological complications may include anger, guilty, and low self esteem levels. There may also be complications as multiple pregnancies and ovarian hyperstimulation syndromes. Success rate of IUI is determined by the cause of infertility, increased age of the male or female partner, duration of the infertility, the number of treatment cycles, the quality of the sperm, and uterine polyps. Hope this video was informative. Thanks for watching and subscribe for more videos.